Hi there, my name is Samuel Williams. I'm a respiratory therapist in the neonatal intensive care. I'm going to talk to you for a little bit about non-invasive ventilation options for managing infants with respiratory distress syndrome, or RDS. So hopefully after this presentation you'll have a little bit of an understanding of how non-invasive ventilation, or NIV, works, be able to state some indications for NIV, and be able to state the benefits of NIV versus invasive ventilation, and know the difference between the three modes of NIV that we're going to discuss, and be able to define respiratory distress syndrome, or RDS. So we'll talk a little bit about RDS. RDS is one of the leading causes of death for infants in the United States. Pretty much all premature babies have some degree of RDS. RDS is caused by the reduction of pulmonary surfactant, and this causes increased pulmonary surface tension. Your lung volumes and compliance will be decreased. Inflammation and epithelial cell injury will also be exhibited. RDS can occur in preterm and full-term infants. Usually with full-term infants, it can be caused by meconium aspiration, aspiration of amniotic fluid from a C-section, a cardiac anomaly, or something that happened during delivery. RDS presents as respiratory difficulty that gets progressively worse. Some clinical signs you would look for would be tachypnea, intercostal subcostal retractions, nasal flaring, grunting, and central cyanosis. If left untreated, infants start to become hypoxic and require increased respiratory support in FiO2. So what you're looking for on your chest rays is like a hazy opacification or a grainy pattern, and then possibly some air bronchograms or little pockets of air. So this is a chest x-ray of a term infant exhibiting RDS from meconium aspiration. You can see that ground glass or grainy appearance, and then you can see some of those little pockets of air, or those air bronchograms. This is a 26-week gestation neonate with RDS. Again, you can see that really hazy, grainy appearance. We'll talk about the benefits of NIV when you compare it with invasive ventilation in infants with RDS. So NIV helps reduce ventilator-induced lung injury and barotrauma. NIV has been really instrumental in reducing BPD rates, or bronchopulmonary dysplasia. And this is caused by prolonged invasive mechanical ventilation. So if an infant's ventilated invasively long-term, those increased pressures can cause the lungs to become overdistended and fibrotic, and then you've got a chronic lung in your hands, and we don't want that. So according to a retrospective 15-year study on NIV, NIV was significantly associated with decreased length of hospital stay, cost, mortality, and reduced the duration of supplemental oxygen. So those are all great things. NIV also makes it easier for parents to hold and bond with their babies and do skin-to-skin, and that's really good for their development because there is no risk of extubation. Things to consider with NIV use. You can have nasal trauma and skin breakdown, feeding tolerance, gastric distension, air leaks. Something to note, in a recent study, the NIV group was associated with higher incidence of apnea and bradycardia when compared to intubated babies. So if your infant is on NIV and having prolonged episodes of apnea and bradycardia, you may have to intubate, and mechanical ventilation may be necessary. Sometimes you just can't get around it. So we're going to talk about three different modes of NIV. The first one is nasal continuous positive airway pressure, or NCPAP. This is the most common type of NIV. You have a set level of CPAP, and that CPAP keeps the airways open and maintains functional residual capacity, or FRC, and that's the amount of air left in the lungs after expiration. So pretty simple, set level of CPAP, infant spontaneously breathing, and that CPAP just keeps the lungs open. So we move on to a little more advanced mode of NIV. This is nasal intermittent positive pressure ventilation, or NIPPV. So NIPPV combines NCPAP, so you do have a set level of CPAP, with additional intermittent breaths by modifying peak inspiratory pressure, or PIP, and you also set a respiratory rate and an I time. So the benefits of NIPPV when you compare it to nasal CPAP. NIPPV normalizes your blood gases faster. FiO2 can be significantly reduced, and a significant increase in pH and PaO2. and also a significant reduction of PaCO2. So when you reduce your CO2 quicker, NIPPV also helps reduce the risk of interventricular hemorrhage, or IVH. And in neonatal world, we're all about reducing head bleeds. So that's a good thing as well. So some of your issues with NIPPV, the big one is the synchronous delivery. So unless NIV is synchronized, the ventilator just gives breaths without regard for the patient's spontaneous respirations. And the breath delivery is also affected by leaks. A lot of times we'll put on a chin strap to close the mouth so that the breaths are delivered more effectively. But then you also have the risk of ventilator breaths being delivered into the stomach. And often the abdomen becomes distended and full of air. And the air accumulated in the abdomen can make it harder for the infant to ventilate because all that air is pressing up on the diaphragm and reducing your lung volume. The air can be evacuated through the OG tube. And that's something that you have to pay attention to when they're on NIPPV. So the solution to that is neurally adjusted ventilator assist non-invasive ventilation, or NIV-NAVA. So how NIV-NAVA works is through a diaphragm electrical activity, or EDI catheter. It's inserted like an OG tube. Your NIV-NAVA uses signals from the EDI catheter to deliver synchronized NIV. So it's communicating with the phrenic nerve and diaphragm activity. The level of pressure delivered can be adjusted on the ventilator by changing the NIV-NAVA level. There was a study in babies with NAVA, and ventilator synchrony improved from 12 to 29% during conventional modes to 0 to 11% during NAVA. So ventilator synchrony is definitely improved by NAVA use. So the diaphragm electrical activity, or EDI waveform, in neonates varies a lot when compared to adults. And that's why NAVA is used a lot in neonatal world, more so than adult world. And this is just a visual image here showing you how much the EDI waveform varies in an infant versus adult. With adults, it's pretty consistent. So as the NAVA level increases on the ventilator, there is a certain point when the infants deactivate their diaphragms. So in NIV-NAVA, when infants deactivate their diaphragms, the ventilator is cycled off and an appropriate tidal volume or pressure is delivered. So this is awesome. You know, using NAVA may be an effective way to avoid intubation or reintubation. There was a study in NAVA at Toledo Children's Hospital with 129 infants, 23 to 28 week gestational age infants, and they were all treated with NIV-NAVA, and 74% of them were successfully extubated after surfactant administration, and they were able to be maintained on NIV-NAVA and then transitioned to CPAP. So NIV-NAVA should definitely be considered to avoid reintubation and, possibly for infants that are failing nasal CPAP. So in summary, avoiding intubation is the best practice in neonatal respiratory care. The best way to ventilate via NIV still needs some more research, but based on what I presented to you here, it would be a good practice to start with NIPPV instead of nasal CPAP in infants with RDS to avoid reintubation after surfactant administration. NIPPV allows for more precise management of blood gases when you compare it to nasal CPAP. And NIV-NAVA definitely appears to be a superior mode of NIV. And these are my references. Just some questions. What is the difference between NIV-NAVA and NIPPV? So the difference between NIV-NAVA is your diaphragm electrical activity catheter, and the breaths are synchronized based on phrenic nerve activity. With NIPPV, the ventilator just gives breaths without regard to this patient's spontaneous respirations. Why is NIV preferred over intubation and conventional ventilation? Well, that's to reduce, bronchopulmonary dysplasia and BPD rates, and to reduce ventilator-induced lung injury. And what is EDI? EDI is diaphragm electrical activity. And what are some clinical signs of RDS? We talked about the chest x-rays being hazy with opacification. And things to look for on your baby would be retractions, central cyanosis, and grunting. And that's it. Thank you for your time. I appreciate it. Have a good one.